So now I would invite our next speakers, Dr. Harshad and Dr. Rakhi, for an interesting debate. We have heard about lots of lifestyle modifications, but we have also will be seeing lots of drugs which have come up. So all these new medication, new drugs would make the lifestyle-based interventions obsolete. So for the motion, Dr. Harshad, and against Dr. Rakhi. So Dr. Harshad.
Thank you. 2.5 months ago, I gave a lecture at the ISG about the virtues of lifestyle modification. And we all heard about hypocaloric diet, just heard about exercise and physical activity. And here I am 2 months later talking about in defense of pharmacotherapy, in other words, anti-obesity medications. Now this is a slide you have seen many times. You find that weight loss is pretty easy. You can lose easily up to 10% of body weight. But the issue is that at the end of 1 year, only about 10% of patients or 10% of individuals are able to carry on that weight. So it's only 1 out of 10 individuals can continue to lose weight. The rest of it, all of them gain weight. So firstly, there's a research to practice or translational gap. Even the most promising lifestyle intervention from randomized controlled trial, and these are very strictly controlled, they tend to lose momentum when translated to clinical practice. So only 1 out of 10. And secondly, individually focused behavior which you see in randomized controlled trial are unable to address the patient's external environment. We live in an obesogenic environment, where the obesogenic environment can overwhelm the substantial efforts that individuals can put in. You have lack of time, lack of space, lack of parks. The food choices are extremely important, increased portion size and high calorie food. And caloric excess as well as sedentary lifestyle. Often you have seen the only walking that patients do or some individuals do is from a TV station to the bathroom. So there again, and there are also the public health infrastructure that have to be addressed by society because we live in an obesogenic environment. Now, what about obesity medications? Weight loss evokes a complete set of neuroendocrine physiological maladaptive response. They are important only for a short period of time. This halt weight, but eventually there's increased weight gain because of all the physiological changes that take place. Anti-obesity medication can help offset this physiological adaptation, and they can help in assisting when you reduce weight. It improves illnesses for more than 193 different illnesses, as well as about 13 different cancers. And what these anti-obesity medications do, they work on the appetite center to reduce weight, and also not just reduce weight, but also reduce or change behavior. Now, we all know that the prevalence of comorbidities in patients who have alcoholic liver disease, I have listed all these comorbidities. It can vary anywhere from about 30% to about 80% of individuals. And often these comorbidities drive non-alcoholic fatty liver disease. This is I took from a magazine just 1 month ago, and you'll notice that the obesity trends in India have nearly doubled. And it's about 40, and 40 is an underestimation. And obesity increases the risk of several diseases that we have all heard this afternoon. Now, if you look at the sheer burden of 1.4 billion population, you find 30% of population, 420 million people with non-alcoholic fatty liver disease. 10% of them develop NASH, it's 42 million. 25% of these MASH, you have 10.5 million patients with cirrhosis. And just 10% of these patients with MASH, you'll have 1.1 million patients with HCC in their country. So even though, even if a small percentage of patients are given the option of anti-obesity medication, it will make a huge difference in the prevalence and the incidence of disease. Now, we keep talking about, I mentioned about obesogenic environment, and I saw everywhere about, Western diet. Ashish also put a slide about pizza. So what about Indian food? We need about 1,500 kilocalories every day. What about masala dosa? It gives you 1,024 calories. What about North Indian thali? 1,800 kilocalories. Mutton biryani, 1,400 kilocalories. And jeera rice with chicken curry gives you 1,900 calories. And we keep blaming the Western diet. So again, Indian diet is very calorie dense. The proportions are large, not just in hotels, but also in school and college cafeterias. So I come to this pharmacotherapy, and again I have only 4 slides, 4 studies to show you. This is a study which did semaglutide in overweight individuals, and you notice that in individuals who received semaglutide, the weight change was 16% compared to placebo, which was 5.7%. Now this is what you might say it was in weight loss, but what about specifically in patients who have non-alcoholic fatty liver disease? 59% resolution of MASH versus 17% in patients. And again, there was resolution of NASH and no worsening of fibrosis. This is specifically in non-alcoholic fatty liver disease. What about tirzepatide? Again, in patients with obesity, and you notice that this is without a traditional intensive lifestyle intervention. You have tirzepatide, 21% weight mean weight change at 72 weeks compared to 3.1% with placebo. So these improvements also translate to reduced risk of all cardiometabolic profiles. And finally, this trial on tirzepatide, specifically in non-alcoholic fatty liver disease, you find 62% resolution of MASH as well as no worsening of fibrosis versus 10%. Now, what does this all mean? It means that these drugs reduce weight in overweight and obese individuals. They also improve cardiometabolic risk profile. They improve resolution of MASH, as I showed you in these 2 trials, and also improve fibrosis. Now, what is the difference in defense of anti-obesity medications? I'll give you an example of about type 2 diabetes mellitus as well as hypertension. Physicians don't wait for patients to fail dietary treatment before you start treatment. Again, we don't discontinue pharmacotherapy either. I heard this statement again and again, you stop this drug, you gain weight. But again, even if you stop anti-lipidemic medication or anti-hypertensive, the hypertension goes up. Severity of disease at presentation. So if you have a patient who has got a blood pressure of 200 by 120, you don't ask them to go lifestyle changes, you give them treatment straight away. So similarly, effective medical or muscle / obesity or diabetes, type 2 diabetes should not be withheld pending patient behavior failure or discontinued. Now this is a physicians heal thyself is a proverb we have heard from 6th century BC, attributed to Hippocrates. And these are physicians who really help themselves, and this is from the New York Times. At cardiology conferences and diabetes conferences, doctors can't help noticing that the colleagues have become very thin because they have started taking this anti-obesity medication. Now we have to extend this same benefit also to patients. What happens if you don't do it? And this is again from New York Times. Bandits, so now it's the bandits are going after the pharmaceutical industry and stealing these drugs. To such an extent, there are security people guarding refrigerators which contain these medications. And what about, and then also cashiers keep their knives there because the bandits are so prevalent that they're scared for their lives. And finally, the mayor who has himself taken these medication and lost weight has promised the same anti-obesity medication to the population. So anti-obesity medications is here to stay. So my parting comments, healthy lifestyle should be universal, should be supported by individuals, policymakers, food industry, as well as environmental measures. Anti-obesity medication to the lower weight as also cardiometabolic profile. And we can move away from this toxic lifestyle versus medical debate. And patients will benefit most if lifestyle interventions is spared with pharmacotherapy to optimize incomes, low body weight, and also its consequences. And this is my last slide. I'll leave you with this quote, and that is, once a new technology or / medication rolls over you, if you're not part of the steamroller, you're part of the road. Thank you.
Thank you, Dr. Harshad. Now, over to Dr. Rakhi.
Thank you, Gorda, sir, for inviting me and making my task so simple, because I think there is no...
Rakhi, I'll just interrupt you. Consider yourself lucky. So our Honorable Minister, Madam, is here just in time to listen to your part of the presentation, and so is Ashok Seth, our chief guest, is here. That's Rakhi Maiwall. She's a professor at ILBS, the institute, and she looks quite a kid, she was a resident long time back, and she continues to be that way. Over to you, Rakhi. Sorry for the interruption.
Thank you. So the topic for the debate is, will the new medications make lifestyle-based interventions obsolete? And I'm totally against that this will ever happen. So let's look at the proposed current management protocol, which all the experts, and many of them are there in this hall and across the globe, Clearly, the first thing is the lifestyle intervention recommended by all societies all across the world, and it is time tested. And again, the most important point that I want to make is, like we talked about the burden, not everybody needs a pharmacotherapy. So a large set of patients with low-risk disease will never require a pharmacotherapy, but it is a separate set of patients where pharmacotherapeutics are required. Now, lifestyle goes beyond like just talking about weight reduction, which has been the main target of most of our pharmacotherapeutic strategies. But what we're discussing is that in a lifestyle program, it's not just targeting and forcing weight, but it is also about a healthy diet, how we make our things better, how to improve the overall health by whatever exercise protocol they can do and improve some institute some lifestyle in their activity in muscle D. I'll not go again through this slide. We know about the benefits. We've already discussed that, again, if you're not even losing weight, you're just exercising, that itself helps not only your liver, but all the other organs which are linked. And again, I want to highlight in this slide, not that what we are forcing our patients is to go to that target weight loss of 10% with lifestyle, but I want to highlight two things. If you achieve that target of 10% with lifestyle, you see 100% improvement in steatosis. So that's the efficacy. Fibrosis, 81%, and NASH resolution, 90%. No drug can ever match that, even if they achieve this target of 10%. And what becomes easy for our patients is to have some kind of target weight reduction. And the basic thing is the compliance, which they are not able to institute. It is easy to take a pill daily, but whatever is easy does not make a disease simple to treat. Aerobic versus resistance. So if the patient is not able to do a good exercise protocol, a resistance exercise with patients who have poor cardiorespiratory reserve is well tested across analysis that improves the overall outcomes of fatty liver patients. Now I'll go again and dig into this data of what is very hyped about is semaglutide. Yes, Dr. Harshad has nicely alluded to the improvement in the NASH resolution, but look at the fibrosis improvement. We know that fibrosis is more difficult, 43% versus 33%, very close. And when we talk about more difficult set of patients, cirrhotic group, the trial was terminated, very small trial of semaglutide, and rather the numbers were on the opposite end. So the placebo was doing rather better in the compensated cirrhosis group as compared to the patients who were given the intervention. We also discussed about the concept of muscle. So we should not forget liver, other organs, adipose tissue, and muscle. So when we are talking about these therapies, one is where you're losing your weight and you're losing some muscle, which is an adaptive weight loss. So semaglutide and tirzepatide, the data is there, yeah. They have variations and they do cause an adaptive weight loss. But we do not still know what is the maladaptive weight loss, where the patient will lose more muscle than fat, and enhancement of the muscle is something which can only be actually can be achieved not just with pharmacotherapy, but instituting a combination of lifestyle and a pharmacotherapy. And how do we do? Rather, it becomes more important when we are putting these patients on semaglutide, their appetite gets poor. It is very important we tell them what do they have to eat. So they have to take a good amount of protein so that they do not lose their muscles. And obviously, the endurance of the resistance exercise should be actually ensured when you're putting up these patients who are morbidly obese on these difficult to eat drugs. And when you do not change the behavior, we are talking about the NAFLD is a behavioral disease. So when you don't change the behavior, you achieve an outcome, but you will not be able to ever maintain that. So sustenance of outcomes requires, for instance, for alcohol, we've treated the disease, but the patient goes back to drinking. You keep doing the same set of things and keep treating with drugs, it will never improve. So again, a healthy behavior is something, and lifestyle should never be forgotten, even if you're able to achieve the targets with your therapies. We do not know the long-term safety data, and more data is coming up in these medical journals about long-term adverse events of these drugs causing biliary disease, pancreatic disease, intestinal obstruction. So already our poor patients who are so sick, they will be further subjected to agony of these bad to very severe adverse events. Central retinal artery occlusion was very hyped about, and again, we do not know long-term safety data. In special groups, so in compensated cirrhosis, decompensated cirrhosis, lean muscle-D, again, we do not know how these drugs are working. Whatever drugs have already been studied, very short term, at 6 months, they've shown improvement in fibrosis. Resmetirom has been approved, but not even 2-3 papers in ASLD which were discussing the real life benefits of resmetirom. And we're still trying to explore more and more drugs for achieving the pharmacotherapeutic benefits. Exercise, we know, is a very good therapy. It elevates your mood, and it also gives so many benefits. So it has to be instituted in a patient as an important lifestyle measure. In our experience at ILBS, we have the only drug, or the semaglutide. We can see here, of the total patients, only 12% we were actually given these patients, and 72% of these patients did not even continue for 6 months, either because of the cost, the adverse events, or they were not achieving the weight reduction. So my key takeaways are, Lifestone remains the cornerstone across all stages, pharmacotherapy only for a subset of patients, weight loss with lifestyle is efficacious, it is a low cost, sustainable without any adverse events. A multidisciplinary approach is required because addressing the behavior is very important. The goal should not be to achieve a goal, but also to wean off these patients of these costly therapies with side effects. So again, lifestyle becomes important. And again, we still do not have long-term data, and we do not know where we stand with respect to the muscle health in these patients. Thank you.
Thank you, Dr. Rakhi. Just one comment for rebuttal, then we end the session.
I forgot to mention the lifestyle is the cornerstone or backbone of all therapies, so it should be continued. But the issue is that you can only the benefits are only seen in about 10% of patients. Regarding the anti-obesity medications, true, there are complications, there are side effects, but so there are side effects for other medications that you take for diabetes as well as hypertension. There are more than 30 plus or 50 odd anti-obesity medications which are in development. I'm sure they'll find out a drug which has less side effects, which is less costly, and which can be taken for a longer period of time. But I agree that lifestyle has to be continued throughout, and anti-obesity medication is only for a small subset of patients.
Thank you, Dr. Harshad. So in the interest of time, we'll not have any questions. We can have a big round of applause for both the debaters. And so with this, we come to an end of this session here. I would request all the chairpersons, moderators, panelists, and speakers to come to the stage for a photograph, and then we end it.